Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about auto-inflammatory vasculitis disease of unknown etiology, that is Behcet's disease. We talk about the prevalence of this disease. It is mostly since ages, it is along the Silk Road route. Silk Route is from the Far Eastern companies, starting from Japan, China, going through the Central Asia and up till Turkey and going up to the Mediterranean Sea. This area is basically the catchment area of this disease. As I mentioned, it comprises of the mouth ulcers, aphthous ulcers. This can be seen in this slide. These are prevalent over there, and these usually heal after 7 to 9 days without scarring. And in the eye, it causes inflammatory conditions involving the posterior segment, as well as it can also involve the anterior segment. If you see the anterior segment, there is ciliary congestion and there is hypopion, but there is no fibrinous reaction. So this type of hypopion in anterior segment is mobile type of. Yes, it can move its direction along changing the movements and direction of the head. So it's a mobile hypopion. It causes different type of skin lesions, pustular lesions over there, erythema nodosum. So these are some pictures showing you the lesions on the legs. Another slide showing the different lesions of Behcet's disease. So basically it is a systemic vasculitis involving the whole body. Coming towards our main topic about what the changes happen in the retina. This is a slide which will show you that there are hemorrhages over there, especially in the nasal side. And along with that, you will see the vasculitis element over there, occlusive vasculitis, and the hemorrhages basically occupying the nasal area. Yes. This is the same fundus photograph mentioning with arrows the location of these lesions, hemorrhages, and occlusive vasculitis. This is a fundus fluorescein angiography. Here you can see in another patient that you can see how the vessels are getting terminated even in the mid periphery. They are not going into the extreme periphery, and you can see some mild leakage in the initial phases. In this slide, you can see blocked hemorrhages over there because of the blocked fluorescence, because of the hemorrhages, and now the dye has started leaking over there from the blood vessels into the retina. This is another FFA photograph showing the early stages where you can see that how the blood vessels are getting terminated in the periphery, especially in the temporal side, and minimal leakage over happening. Blocked fluorescence with more leakage over there. Now even the temporal side you can see some leakage of the dye over there. Yes, nasal as well as temporal side. Another FFA photograph showing you the blocked fluorescence nasally, and if you concentrate on the temporal side, the vessels are not going up to in the periphery with minimal leakage over there, retina taking over the dye. Another FFA photograph showing you the blocked fluorescence nasally, and if you concentrate on the temporal side, the vessels are not going up to in the periphery with minimal leakage over there, retina taking over the dye. Another patient, you can see here how profusely the dye is getting leaked over there and getting distributed into the retina. These vessels cannot hold the dye, they are fragile, they are leaky, that's why it gets leaked over there into the retina. This is this types of the FFA you usually get when there is so much vitritis that the image is not very clear as shown in this. So even then the FFA helps us to locate and find out the leakage of the areas and dyes and the position of the conditions of the blood vessels. So when the media is not very clear, when there is so much vitritis over there, hazy media, so you get such types of the FFA. There's another FFA with acute vitritis, but still you can see the dye distributed into the different areas of the retina. To the B scan in these patients, you will find these are because there is so much inflammation is going on over there, so much element of vitritis is over there. So you can see such type of B scans, vitreous opacities, vitreous haze. But the retina looks normal in this patient, but vitreous opacities and haze, all these things can be appreciated in this ultrasound section. And that much activity is going on over there in the retina. It also involves the macula, and you can see here in this patient how the fluid is over there, subretinal fluid and macular edema, all these things in the OCT macula. We will discuss all these things, treatment modalities in detail after that. As mentioned, this is a disease mostly prevalent in Far Eastern countries, and also it goes up to all the old trade route of the Silk route, Central Asia, and then going to the Mediterranean and Turkey. So prevalence is quite high in the Turkish population, more than 420 patients per 100,000. And this disease is basically etiology is uncertain, but it has been found that it has correlation with HLA-B51, and some hypothesis has been done about considering the etiology about different microorganisms. For example, Streptococcus sanguinis, Staph aureus, herpes virus infections, and Prevotella species. These also have been documented. But basically, it is HLA-B51 associated disease. The patient, if we talk about the age, it is between 20 to 40 years of age group. The patients are, people are involved. If we talk about the gender distribution, if we come towards the Arab countries, it is mostly males are more involved in this disease. And if we go towards China, Japan, these areas, Far Eastern countries, it is female population which is mostly involved, gender population. So males and youngs, when they are involved, they are severely involved. And this disease, when we talk about this genetic disposition, genetic involvement, it does not follow the Mendelian mode of transmission. It is not autosomal recessive, dominant, X-linked, no, nothing like that. Sporadic familial clusters have been found, and as I mentioned, genetic role is that much. I mentioned HLA B51. So mostly if you talk about the country-wise, as I mentioned earlier, 420 per 100,000 people in Turkish population. I mentioned it is auto-inflammatory disease involving all the arteries and veins of different sizes and types, but it is vasculitis is not necrotizing type, and there are no joint cell formation in this type of vasculitis. Yes, this is a classical point about these diseases, and when they involve the pulmonary area, they involve the arterial area over there, they can form the venular area, they can form unique pattern over there, venular involvement and formation of pulmonary and arterial aneurysms over there. And as we have seen earlier in SLE, there are no autoantibodies in this disease. Talk about the pathology, it is basically cell-mediated immunity. The T cells levels are increased in this. Type 1 helper T cells lead to the activation of and increased T cells over there. Cytokines are released, interleukin-1, 8, 12, and different tumor necrosis factor. And all these ultimately contribute to the increased macrophage activation. Yes, and neutrophil chemotaxis and phagocytosis in the lesion. So basically the neutrophil complexes are activated over there. If you see about the mucocutaneous lesions, the causes oral ulcers, genital ulcers, edema, nodosum, these are all because of the increased neutrophil activation. So neutrophil vascular reaction leads to the tissue injury. Yes, this is basically caused by the neutrophilic vascular reaction that causes the injury over there. Talk about the histopathology. Basically, in these diseases, we know the different sections of the blood vessels. Vasa vasorum is also involved in this. So neutrophil predominant reaction happens with endothelial cells getting swollen up over there in the blood vessels. This leads to the extravasation of the RBCs and leukocytoclastic vasculitis over there. So fibrinoid necrosis of the blood vessels happen over there. Later on in this disease, lymphocytic involvement is also there. So basically, as I mentioned, it is neutrophilic vascular reaction which is the main culprit, which is causing all these damages over there. Lymphocytes in later stages usually are found. Mentioned by Dr. Behcet's in 1937, still same three things very important: oral ulcers, genital ulcers, and eye involvement. This is a triad of this. The oral ulcers usually heal without any scarring. Yes, but genital ulcers, when they heal, they cause scarring over there. I mentioned the most important thing is the presence of recurrent oral ulcers in these patients. 3 episodes in last 12 months. This is the most important thing. After that, any two of these things present, they make very important in the diagnosis. For example, recurrent genital ulcers. As I mentioned, they heal with the scarring. If eye lesions, they may be anterior or posterior, or maybe panuveitis, and these cells can be seen on the slit lamp, vitreous cells, and there may be retinal vasculitis. If we talk about the skin lesions, as I mentioned, erythema nodosum, papulopustular lesions, acneiform lesions over there can be formed. And pathology test much talked about. This is you prick the skin with a 20 to 25 gauge needle, and after 24 to 48 hours there is a papule formed over there, 2 millimeter. So this is a test, but not very confirmatory, but it can help in the diagnosis. From the grading system and classification I mentioned over there before, there are also ICBD criteria. According to this criteria, there is a point scoring. For example, they have given ocular lesions 2 points. For example, retinal vasculitis, chorioretinitis, papillitis, there 2 points are given for that. Oral aphthous ulcers at 3 times in 1 year, if they happen, 2 points are given. Skin lesions, 1 point. CNS, yes, this disease also involves the central nervous system. Wherever there are blood vessels, this disease can cause effect over there, get damage. So if the CNS involved, for example, parenchymal and CNS involvement, venous sinus thrombosis, 1 point. And vascular manifestation, if we talk venous thromboembolism, superficial thrombophlebitis, they have given 1. So positive pathology, 1 point. So if their total score is more or equal to 4, according to ICBD, he's having Behcet's disease. Yes, and there is also talked about another way for the classification. This is BOS 24. So there are different ways to classify, grading, and scoring of the disease. As I mentioned, in retina, in the eye, it is defined as the chronic, relapsing, bilateral, non-granulomatous panuveitis and retinal vasculitis. Yes. If you see any patient having acute anterior uveitis, they make up usually 10%, not more than of the total patients suffering from this. So basically, it is occlusive necrotizing retinal vasculitis. The blood vessels start getting closed up. Yes, periphlebitis, perivascular, diffuse white haziness, arteriolitis, thrombosis leads to the bilateral inflammation on branch retinal vein occlusion. So basically, thrombosis leads to the occlusion of those areas. The areas become ischemic, blood vessels gets leaked over there, retinal neovascularization happening over there. And these new vascularization, as we always know, that these new vessels cannot hold the blood, they are leaky, the blood hemorrhages gets over there. So all these things are going on over there. So basic thing is it is occlusive, necrotizing retinal vasculitis. Yes, this is the basic its pathology. So basically, breakdown of blood retina barrier happens because of inflammation, and in perifoveal area you will see capillary leakage leading to the cystoid macular edema, as I showed in you in OCT. Apart from this, there is also vascular leakage within the optic disc, peripheral retina, macula, as I showed you the FFA slides earlier. So as I told you earlier, some slides were not very clear in FFA because of the vitreous haze. Active inflammation when going on over there, the media is not very clear. Vitritis is usually most prominent during the initial attacks and dissolves gradually. And its pathognomic sign is that pearl-like peripheral inflammatory precipitates are organized in a linear pattern. Yes, pearl-like peripheral inflammatory precipitates are present in a linear pattern 4 to 7 days after the initial attack of uveitis, which later on disappear. This is the pathognomic of this disease. Hypopyon, there is no fibrinous reaction, so this is a mobile hypopyon. It changes its location, is a poor prognostic factor. Anterior segment inflammation, if we talk, there is mild ciliary congestion, diffuse endothelial dusting, and normal or low intraocular pressure. When also that much inflammation is going on, ciliary bodies are also involved. Their production of aqueous humor is also compromised, so it is possible to have low intraocular pressure. Yes, and there are no mutton fat KPs, or if we talk about chronic cells or chronic high-grade flare. As I mentioned, that OCT is quite helpful. So the thickness of the retina, central macular thickness, is usually mean, and the volume are increased. Even though there is no macular edema, these two things increase over there. FFA is the gold standard still. Spectral domain OCT is very helpful, but for the subclinical thickening and subclinical changes, you have to get the help of enhanced depth imaging OCT. That is very helpful. Studies have been done about the ganglion cells, what is happening over there. So parafoveal cells are already decreased, but it has been seen by different researchers that the perifoveal cells initially over there, due to the occlusion of the superficial capillaries, the vessels perifoveal, they increase, and later because of the occlusion of the superficial capillary vessels, they decrease due to the ischemia, as it earlier happened in the parafoveal area. OCT angiography also being used, basically superficial capillary plexus and deep capillary plexus over there in the macular area. There is hypoperfusion and non-perfusion going on over there. So capillary vascular density is decreased, and foveal avascular zone is increased. Yes, OCTA. If we talk about the peripapillary nerve fiber layers, they also have been mentioned that they also increase over there. Yes, as the edema and all these things are going over there, so peripapillary nerve fibers are also increased, and they also contribute to the decreased vision. FFA leakage, it can happen at disc, macula, periphery of retina, anywhere possible. So this has also grading system, 0 to none, 1, mild and moderate severity. It has been done. If we talk about the autofluorescence, yes, there may be modified hypo autoreflectivity to hyper autoreflectivity. This is because of the pigmentary cell changes going on, and vascular changes. All these things happening, vascular changes in choroid, which are contributing to the hyporeflectivity and hyperreflectivity. VEP is basically experimental for optic nerve and for the Behcet's uveitis patients. Yes, it can be done for them if it is available. If we talk about the central corneal thickness is increased. It is understandable that whenever the endothelium pump is compromised, it is affected because of that much uveitis inflammation. So it will swell up, it will increase in its thickness. The patient comes to us, apart from the basic investigation, blood works, CP, renal profile, liver function tests, we can do C-reactive protein for these patients. We can do double stranded DNA antibodies. There are genital lesions, so syphilis test should be done. Apart from this, as we are going to put these patients on immunosuppressants, so PPD test for tuberculosis, quantiferon for tuberculosis, and even a chest CT scan, these things should be done in these patients. So there are multiple treatment available with us, which immunosuppressants which we can use. For example, azathioprine, this is very good, and cyclosporine, they have shown very good success and highest level of evidence and strength for posterior uveitis. Apart from this, cyclosporine is usually not indicated and not good when the patient is having Behcet'S disease. Yes, it is contraindicated. And along with this, cyclophosphamide and mycophenolate mofetil. So we believe that a very good combination will be infliximab and mycophenolate mofetil. Yes, and this disease can be controlled if properly treated and investigated. I want to thank my respected audience for their attendance and attention. I hope they will be beneficial for their clinical practice. Thank you.